Dear audience, Assalamu alaikum. I am Dr. Saklin Russell, working as the Assistant Professor, Department of Vascular Surgery, Eingland Hospital and Research Institute. Welcome all to this session. Actually, আজকে রমজান মাস শুক্রবার সকালবেলা একটা ক্লাস করতে বসা সত্যি সবচেয়ে বড় কঠিনতম একটা বিষয়। আপনারা যারা এই কঠিনতম বিষয়টাকে সহজ করে এই মুহূর্তে নিজের ক্যামেরার সামনে বসেছেন তাদের সবাইকে স্বাগত জানাচ্ছি। আমরা সরি যে আমাদের একটু টেকনিক্যাল কারণে শুরুটাতে কিছুটা সময় আমরা আপনাদের হাত নিয়েছি, সেই জন্য আমরা দুঃখ প্রকাশ করছি। আপনারা জানেন যে আজকে আমাদের নির্ধারিত ক্লাসটি হচ্ছে COVID-19 আন্ডারস্ট্যান্ডিং দ্য ডিজিজ। Today's master class is going to be taken by our renowned Professor F.M. Siddiqui. Before going to my presentation, let's have a short biography of Professor F.M. Siddiqui. Professor F.M. Siddiqui graduated from Sher-e-Bangla Medical College, Borishal. He did his internship in IPGMR, that is known as BSMU, and he was the Assistant Registrar and Registrar of Medicine in Mymensingh Medical College. He did FCPS in Medicine in 1981. He worked as a resident physician and assistant professor of medicine in IPGMR from 1991 to 1995. He worked as associate professor and professor of medicine at Dhaka Medical College from 1998 to 2008. Professor Siddiqui started showing his talent as a teacher while he was a registrar of medicine in Mymensingh Medical College. He became very prominent. He was teaching in Dhaka. While he was registered in medicine in Mymensingh Medical College, he became very prominent while he was teaching postgraduate students in IPZMR. While teaching in Dhaka Medical College, he reached his peak as an excellent teacher and unparalleled clinician. He had a profound impact as a teacher to all of his students, who still follows his guidance and teaching in their personal and professional life. Professor F.M. Siddiqui was the Secretary General of Bangladesh Society of Medicine from 2002 to 2006 and single-handedly took the society into the internal forum. Professor F.M. Siddiqui has more than 100 publications in national and international reputed journals. He was contributed to develop different national guidelines. Now he is working as a professor of medicine and consultant in Labaid hospitals, Dhaka, Bangladesh. আমি জাস্ট এক মিনিটে আপনাদের একটু জাস্ট বাংলায় একটু বলতে চাচ্ছি যে আমরা যখন ঢাকা মেডিকেল কলেজের স্টুডেন্টস ছিলাম, আসলে আপনারা সবাই জানেন যে সকাল ঠিক 7টায় ক্লাস করা সবচেয়ে কঠিনতম একটি বিষয় ছিল। বাট প্রফেসর এফ এম সিদ্দিকী স্যার যেদিন ক্লাস নেবেন সেদিন সবচেয়ে কম সংখ্যক স্টুডেন্ট ঢোকার সেখানে সুযোগ পেত, কারণ আমাদের অনেকে দাঁড়িয়ে থাকতে হতো। আজকে সারা বাংলাদেশে তার স্টুডেন্টসরা যেরকম ছড়িয়ে আছে, আজকে আমরা প্রযুক্তিকে থ্যাঙ্কস জানাতে চাই, করোনাকে থ্যাঙ্কস জানাতে চাই যে প্রযুক্তির কল্যাণে আজকে করোনার কল্যাণে স্যারকে আমরা আবার ফিরে পেয়েছি। এত পরিমাণ রেসপন্স স্যারের ক্লাস করার জন্য আমি জানি না যে অ্যাকোমোডেট করায় ডিজিটালি কতটুকু সম্ভব হবে, তারপর আমরা চেষ্টা করবো আজকে স্যারের ক্লাসটা এনজয় করার জন্য। আমি আবারও থ্যাঙ্কস জানাচ্ছি যে স্যার আবারও আমাদের জন্য নতুন করে বিষয়টি নিয়ে এসেছেন। So now the floor is open for our honorable speaker, Professor F.M. Siddiqui. Please start, sir.
Thank you, Saklin, for giving a brief and talking nice things about me. That really made me very nostalgic of the times we actually when I was a teacher in Dhaka Medical College. Anyway, Bismillahirrahmanirrahim. Assalamu alaikum. Happy Ramadan and good morning to those who are in the webinar and live in Facebook. Today, I will give a discussion on COVID-19, understanding the disease. I say it because my topics in this lecture is completely dedicated for doctors and especially doctors and primary care doctors who are involved in the management and of the disease which has taken away the whole of the world as by surprise. First of all, let's start with the disease onset. 31st December 2019, China first reported to WHO that a pneumonia of unknown etiology at Wuhan City, Hubei province. On 8 January 2020, China officially informed that they have identified the cause, and this pneumonia is done by a novel coronavirus. That period of time, the virus showed potentiality of human to human transmission. 30th January 2020, WHO declared the disease as public health emergency of international concern. 11th February 2020, WHO named the new coronavirus disease as COVID-19, and International Coronavirus Study Group named the virus as Severe Acute Respiratory Syndrome Coronavirus 2 SARS-CoV-2. So the virus which is causing disease is SARS-CoV-2, and the disease which is caused by this virus is named as COVID-19. 11th March 2020, WHO declared the COVID-19 as pandemic. I mentioned these deadlines because it took 2 months and 10 days for WHO to declare the disease a pandemic, which from its beginning, it showed its potential to become a pandemic. So there would be a lot of discussion after post-COVID era that what could have been done. It seems that whole world was waiting and watching to see the virus originating in China and take away the whole world sweepingly, just nobody could do anything. First of all, let's see the epidemiology of the virus. Coronaviruses are classified into 4 genera: alpha, beta, gamma, and delta. There are 7 coronaviruses which are involved in human disease. There are thousands of species of coronaviruses, but only 7 they are involved in human disease. Of these 7, there are 4 coronaviruses that are of human origin. These 4 coronaviruses are 2 alpha. Of these 2 alpha, HCoV229E and HCoV-NL63, and 2 beta, HCoV-HTU1 and HCoV-OC43. Their existence is known since 1960. And these viruses are responsible for seasonal flu-like symptoms throughout the world. In fact, 10 to 15% of yearly viral flu is due to these human coronaviruses. Coronaviruses of animal origin, that is really causing havoc, is 3 types. There are 3 beta coronaviruses. They are of animal origin, causing disease in human. That's why they are known as zoonotic disease. Zoonosis. How did virus come into human? Primary, all these 3 beta coronaviruses originated from the bat. First reported beta coronavirus was SARS-CoV during the period of 2002 to 2004. First mutation of this virus occurred in the bat. Then the virus jumped into the intermediate host. That time it was thought to be civet cat. And second mutation occurred in the civet cat, and the virus then finally jumped into the human. Second coronavirus, which is originated after first mutation from bat, is March coronavirus. Its intermediate host was camel, domestic camel. March coronavirus causes Middle East severe acute respiratory syndrome, and then it jumped into human. And the virus of today, which we are going to discuss, is SARS-CoV-2 2019. It is also originated from primary host bat. First mutation, then second mutation occurred in pangolin, and then it jumped into human. Case fatality rate has to be calculated because it is very important that we know the severity of the disease by case fatality rate. First SARS that originated in Guangdong, China in 2002, it persisted throughout 2003, then for some other reason, it disappeared in 2004. Total case recorded that time confirmed was 8,096. Total death recorded was 774, and case fatality rate was about 9.5%. Middle East respiratory syndrome originated in Saudi Arabia in the year 2012. Total case recorded that time was 2,500. Total death was 850, and case fatality rate was 34%. COVID-19, as we know, originated in Wuhan City, China, December 2019. Until today, confirmed cases are more than 4.2 million, and total deaths is going to exceed 300,000. I took from WHO, and it is in WHO showing still the total death is 294,046, and case fatality rate is 6.92%. Here, one important point I like to emphasize that if the total number of the cases could have been confirmed by investigation and testing, then as the number of confirmed cases goes up, and that due to that time, case fatality rate usually goes down. So total case number usually considered to be much higher, and the death case fatality rate would be, if we count the total number of real cases, would be much lower. This is in short Bangladesh data I'm going to show you. Total cases according to WHO recorded is 17,882. Total death 269. Case fatality rate is of 1.50%. Now you see, first case recorded was at 8th March. There were 3 cases. 8th April, the number of cases jumped to 218, and 8th of May, you see the cases in Bangladesh is exceeded 13,000, and now it is more than 17,000. So the curve in Bangladesh is going up. It will continue to go up, it seems, and we don't know when it will take a plateau. There are 2 most important epidemiological terms I would like to highlight, because to understand the transmission epidemiology of the disease, we need to understand these 2 terms. First is R naught. This term indicates that average number of people who will contact a contagious disease from one person. This is very important to understand the disease transmission and making model or projection of disease transmission and fatality and other things. So calculated COVID-19 R naught is about 5.7. It was considered early that the calculated R naught to be 2.5, but recent publication shows that actually it is 5.7. To compare it with seasonal flu, the calculated R naught of seasonal flu is about 1.3. I will show you why this comparison is important. Another epidemiological type that is serial interval. This indicates time from symptom onset in primary case to symptom onset in secondary case. That is, in case of COVID-19, thought to be 5 to 7 days. Now, I show you how COVID-19 is exponentially growing. This is the first case. Consider that this disease started in this case. As we know that R naught of the disease is 5.7, so we will take into consideration that this person will transmit the disease minimum 5%. So this is the original person carrying the virus. He will transmit the disease at least to 5% within a span of 5 to 6 days time. These 5%, each of them, within next 5 to 6 days time, will transmit to 5. So totally, these 5 will transmit the disease to 25 people. And as each of these 25 will transmit the disease to minimum 5%, so the total disease to be transmitted from these 25 would be 125%. Now you see a single person originating the disease from him within a span of 15 days, 2 weeks time, 155% got infected. So that is the reason why the whole world is getting crazy for lockdown, why the whole world is giving much importance to tracking the cases, isolation, quarantine, case detection is important. Because if we could have prevented this person from coming into the community, we could have prevented this fight. And if we could have prevented this fight, we could have prevented this 25, and vice versa. This is how the exponential transmission of COVID-19 is going on, which is unprecedented and it is not seen. Now I show you the comparison. What happens with seasonal flu? Seasonal flu R naught is about 1.3. So what happens? One case, it transmits the B325 to another case, then it is transmitted to next person and transmitted to another person. So the transmission is static. So if we put it in a graph, we can see that the growth transmission of COVID-19 is exponential if it is unmitigated, unchecked. But comparing with that, flu, it is flat, the curve is flat. So depending, making this as a taking is as a calculation, it has been calculated that 82% of the population will have to be immune either by the disease or by vaccine to stop transmission to disease, which will give a herd immunity. So those who talk about herd immunity, they must keep it in mind that for COVID-19 to get herd immunity, 80% of the population needs to be immune, either by the disease or by vaccine, which is virtually impossible task to do. Another important aspect, all of us will know by this time how the disease is transmitted, but we need to discuss a little bit. First of all, direct transmission, which is done by respiratory droplets and aerosols. This is person to person. Both symptomatic and asymptomatic persons at an early stage of disease. It is assumed that a person asymptomatic who starts shedding the virus 2 to 3 days before the onset of symptoms, and cough, sneeze, and coughs initiates the shedding of the virus, and any person within the vicinity inhaling that can get the virus directly. Another important mode of transmission is from points. That means touching an infected surface with hand and then touching own eyes, nose, and mouth will cause transmission of the virus. Another less important but documented is fecal-oral route. Small percentage can get transmission of the disease. Now I come into the main part of my discussion, which is pathophysiology of the disease. No other disease needed understanding pathophysiology so much so like this SARS-CoV-2 did. Because if you don't understand the basic pathophysiology of the disease and the virus, you will not be able to understand actually changes, what going to happen and what exactly happening in the patients and what is going on in research. First, we see the virus. As you can see, coronavirus is a large RNA positive sense RNA virus. It is surrounded by lipid bilayer envelope. And you can see that there are proteins embedded into this lipid bilayer membrane. And one of the most important protein is glycoprotein S. This is giving rise to spike-like. And as the virus is surrounded by this protein spike, it looks like crown of king, and the name corona came from this protein. There is another important protein, as you see in the black. This is called membrane protein, and also another protein reddish, which is called envelope protein. These proteins are very important. This is together with the nucleocapsid protein. Basically, this nucleocapsid protein keeps the virus RNA in steady state. So all these structures needed to be understood a little bit for the virus to understand. Now, how the virus infects the human. As we know, the virus enters into the body by inhalation. Once it enters into the body by inhalation, the main organ it reaches is alveoli. In the alveoli, there are two types of epithelial cells. These are known as type 1 and type 2 epithelial cells. Type 1 epithelial cells are involved with gas exchange, and type 2 epithelial cells are involved with very important function, that is secretion of surfactant, which actually maintains the alveolar elasticity and prevents it from getting collapsed. As the virus enters into the alveoli, it gets attached with the receptor at the membrane of the type 2 pneumocyte by its spike protein. Now, this attachment of virus with the pneumocyte with this enzyme is known as angiotensin converting enzyme 2. This binding is not enough to cause the virus to enter into the cells. So there is another protein which comes from the side. This is known as transmembrane protein, TMPRSS2. This causes a cleavage with the virus and allows the virus bilayer membrane to fuse with the host cell membrane, and then it pulls the virus inside the cell by a process which is known as endocytosis. Once inside that cell, the virus releases its RNA into the cytoplasm. This is known as uncoated. So this is the viral RNA in the cell cytoplasm. As you can see, this is a positive sense coronavirus. So within the cell cytoplasm, immediately ribosome starts translating the virus. And by this process of translation, it produces protein, two types of protein. This is replicase protein and transcriptor protein. One of the important protein is RNA-dependent RNA polymerase. So after generating this protein acts on the same RNA like this. And then it replicates its own RNA and makes a template, which is coronavirus RNA negative sense RNA. And then this replication causes production of multiple copies of, again, this enzyme passes through this negative sense RNA and causes production of multiple copies of RNA which are exactly same as the original RNA which was entered from the virus. Now what happens is this RNA, which is replicated production of RNA, it exactly causes when this RNA which is being replicated and produce copies of virus, this is not enough. As you have seen, the virus needs also protein to be synthesized, and that actually how this protein is synthesized. As you can see, the same virus, it reproduces itself by copying this negative sense RNA into positive sense RNA. At the same time, by virtue of this transcriptase enzyme, it synthesizes some of the proteins within the cell cytoplasm. So you have the virus got its own RNA and its protein. With these two raw materials, it transfers it into the rough endoplasmic reticulum of the cell. Within the rough endoplasmic reticulum, this viral RNA, newly synthesized RNA, and protein gets assembled. And from there, it is transferred into Golgi complex within the cell. And within this Golgi complex, they are further assembled and viral particles, viral proteins are produced, and they are released into the cytoplasm as vesicles. And from these vesicles, they are extruded from the cell by a process which is known as exocytosis. Why you need to understand this process? Because if you don't understand this process, you will not be able to understand where the drug acts. For example, remdesivir. Remdesivir, where it acts? It acts actually when the virus produces its copy from positive sense RNA to a negative sense RNA viral copy template. This remdesivir medicine gets incorporated into this negative sense RNA, and it does not allow the RNA dependent RNA polymerase to properly translate the virus and thereby inhibits the production of viral RNA copies. Similarly, hydroxychloroquine, it acts at the entry of the cell, and it not only there, it also acts into the cytoplasmic area where it can change the viral environment to stop replications. So this, when there will be new drugs available in the market, if you remember this viral cycle, how it reproduces, then you will be able to clearly understand in which part exactly the medicine works. Now, as you can see, one virus entering into the cell and it is producing multiple copies. And this way, within 5 to 8 hours after entry into the cell, millions of viral copies are produced and they start spreading in the vicinity within the surrounding cell. And that's how it starts causing infection. Now, body cannot sit idle and just watch, see what happens. Body has got its own defense system. I will show you how body initially responds when the virus invades into the body. First defense system of human body which comes to play is innate immune response. And you will heard a lot of talks about innate immune and adaptive immune system, especially how it is working in this COVID-19 cases. Because you know, this disease doesn't have yet any specific drug. So we are solely dependent on our immune system for our survival. Now I show you, this is an alveoli, and as you can see, I draw it in a way so that you can understand. These are the type 1 pneumocytes, and this is type 2 pneumocyte. So as I showed you in the circle, that the virus enters and affects the type 2 pneumocytes. This is alveoli, this is the alveolar capillary. So once virus invades type 2 pneumocytes, it immediately understands that it has been invaded by a foreign virus. So it causes release of an cytokine, which is known as interferon alpha. This interferon alpha is very important. It causes immediately three things. First, it goes into the surrounding pneumocytes and informs the pneumocytes that it has been invaded by a foreign virus. And whenever the surrounding cells gets information by interferon alpha, they have got by default, they have got genetic mechanism by which they produce antiviral proteins. And these antiviral proteins stops invading the cells in a way that they stop synthesis and uh, replication of the virus. Second thing interferon does, there are alveolar macrophages. This virus causes stimulation of the alveolar macrophages. Alveolar macrophages, once they are stimulated, they are together with their, it causes another thing, which is it stimulates natural killer cells. So these are the three immediate defense systems comes into play. One is protection of the surrounding cells from the viral invasion, activation of the alveolar macrophage, and activation of the natural killer cell. What they do, the alveolar macrophage, as soon as it is activated, it causes release of cytokines, IL, interleukin 1, H6, interferon gamma, and tumor necrosis factor alpha. Not only that, it also causes release of one important thing, that is chemokines, CXCL10, CCL2. These chemokines are important for inviting neutrophils within the alveoli. So, natural killer cell, macrophage, and neutrophils, they come into play immediately, and they take control of the situation and tries to contain the infection before it gets spreaded. This is not only the defense system, there is another defense system becomes activated, and that is adaptive immune system. This system is highly specific and very powerful. In the alveoli, we all know that there are dendritic cells. Dendritic cells together with alveolar macrophages swallow the virus, process the viral protein and project it in the surface, and takes this viral protein to the regional lymph node where there are CD4 T helper cells. Once these viral proteins are presented to T helper cell CD4, immediately they cause release of two important cytokines. One of the important cytokine is T helper 1 cytokine. This cytokine acts on naive CD8 T lymphocytes, and this, by the stimulation of T helper 1 cytokines, this naive T lymphocytes starts immediately proliferation and maturation. Once they are proliferated and matured in several thousands, they become cytotoxic T lymphocytes. These cytotoxic T lymphocytes are highly specific against this SARS-CoV-2. What they do, these cytotoxic T lymphocytes immediately goes at the site of infection, and they causes destruction of the infected cells. Not only this, these cytotoxic T lymphocytes remains in the system as memory cell. As I said, there is another set of T helper 1 cytokine, and that is T helper 2 cytokine is released. And these T helper 2 cytokines, once released, they act on B lymphocytes. Under the stimulation of T helper 2 cytokines, B lymphocyte starts proliferation in thousands, and they become plasma cells. These plasma cells are highly specific against this virus, and they cause immediate release of antibody. Actually, this antibody we are trying to test to identify specific virus. Initially, they release IgM antibody, and then later on they release IgG antibody. This antibody goes into the site of infection and helps the system to eliminate the virus by its destruction. And the B lymphocyte, highly specific B cell lymphocytes, they remain in the system as memory cell. And these T lymphocyte and B lymphocyte memory cells, on which we are depending on those who got COVID already infected, and those are infected, it is thought that they may have this memory cell. Now the question remains that whether this immunity is long lasting or not. Now what happens? About 80% of COVID-19 patients, this innate and adaptive immune system works perfectly and patients recover either with mild or moderate disease. As you can see, the disease has been taken control by body's own system. But unfortunately, 20% of cases, its immune system fails to work properly. And that's why we see severe disease and critical complications. Now, if I make a spectrum of the disease of COVID-19, you will see that day one, as the virus enters into the body, innate immune system starts working against the virus. And by the time day 5, we see the activity of adaptive immune system taking over. This innate and adaptive immune system working together is sufficient to take control of the virus. And by the time 10th day onwards, 80% of infected persons gets recovery. Only 20% enters into severe and critical disease. And by the day of 18 to 22, either maximum either recovers or patient succumbs to death. Now, who gets severe disease? This is one important question to be answered. Normally, as you have seen, the innate immune systems works by macrophages, neutrophils, and natural killer cells. These three cells causes efficiently destruction and elimination of the virus. Then also comes the adaptive immune system. There are two arms of adaptive immune system. One is by cytotoxic T lymphocytes, another is plasma cell producing antibody. And both these systems, when work together, innate and adaptive immune system, they perfectly in synchrony work. And they, after completion of their job, they provide a negative feedback for optimum immune response. This is very important for the body. Body cells has to understand when it has to be stopped. And everywhere in physiology, you will see that there is a negative feedback system prevailing, causing normal harmony of the body function. Natural killer cells, cytotoxic T lymphocytes, what they do, actually they clear the area of battlefield. They clear the affected cells, damaged cells, and also stress cells together with macrophages. Both these natural killer cell and cytotoxic T lymphocytes also send signal to the macrophage to stop because the disease has been taken control of, the virus has been eliminated. So under the influence of these, now macrophage gets signal. In these groups of patients, those get severe disease, the antibody response is inadequate. The natural killer cells and cytotoxic T lymphocytes fail to clear the damaged cells, and at the same time, they fail to inhibit the macrophage activity. So disease which started as a viral disease turns out to be immunologically mediated disease. And now I show you what happens exactly when the disease gets severe. Now this macrophage doesn't get any inhibitory signal from this natural killer cell and from other cells. So what happens? They continue to produce cytokines, interleukin 1, 8, 6, interferon gamma, interferon alpha. So once these cytokines started release uncontrolled, they cause, this is alveolar capillary. They cause dilatation of the alveolar capillary. Not only that, they cause increased permeability of these capillaries. So fluid from the capillary starts oozing out into this space, which is known as interstitial space. As the process continues, these fluids tends to come more and more, and the patient starts getting breathless. This fluid not only accumulates into the interstitium, it also presses the alveoli from outside. And at one point, it starts pouring into the alveoli, giving rise to alveolar edema. At this stage, if you do chest X-ray or CT scan, you will see the ground glass opacity. And this represents mostly that there is interstitial and alveolar edema. Now the patient started getting breathless, and as the process continues, he gets more breathless because of alveolar edema. That causes another problem. As we know that oxygen diffuses from the alveolar into the capillary of the pulmonary capillary, so diffusion of oxygen becomes hampered and difficult because of this alveolar edema and interstitial edema. So partial pressure of oxygen starts going down. As it continues, then the patient develops hypoxemia. This hypoxemia causes further breathlessness. And not only that, there is carbon dioxide which should go out from the capillary into the alveolum for to be expelled. The carbon dioxide could not go efficiently out of the circulation, so they start accumulation, and there occurs increased retention of carbon dioxide. This, together with what happens, is that, as I said, that chemokines released by macrophages, these chemokines comes into the alveolar capillary epithelium, and they cause their capillary endothelium to capillary endothelial cells to liberate two important things, and this is called vascular cell adhesion molecule. This vascular cell adhesion molecule is actually, these neutrophils, you can see, do not know, actually they have no clue where they need to go. Millions of neutrophils are circulating into the blood. So when these chemokines produces, see, this vascular cell adhesion molecule, they trap the neutrophils. Actually, they give the neutrophils clue where to go and to act. So millions of neutrophils start pouring into the alveoli. This neutrophil not only phagocytoses the virus, it causes release of proteases and other enzymes, which not only causes destruction of the virus, it also causes destruction of the epithelial cells. Now, this accumulation of neutrophil, this alveolar edema, together with macrophage, natural killer cells, and debris, give rise to a picture of consolidation. So, features of consolidation you start seeing after, as you see the ground glass opacity. Patient starts getting more and more breathless because of this. And also there is reduction in surfactant production because pneumocytes are inactivated by the virus. As surfactant production goes down, there is tendency of alveolar collapse, and together everything, when it gets full-blown picture, the patient gets the picture of ARDS, acute respiratory distress syndrome. Now, I must emphasize on the fact that very small minority of patients gets up to this stage of ARDS, very minor number of patients. Let's see, this is what happens into the lungs and alveoli. Now, other things that happens is interleukin 1, interleukin 6, and tumor necrosis factor alpha released and comes into the circulation. In the hypothalamus, they goes and they cause production of prostaglandin E2. And this prostaglandin E2 resets the thermostat of hypothalamus, and that gives rise to very high fever. And a significant number of patients gets very high continued type of fever. This is one very interesting observational study I want to show you before I proceed, because this needs to be understood, that what is happening in the lungs. United Kingdom Intensive Care National Audit and Research Center have published a very important data recently. And they say that the mortality in COVID-19 patients, those who required ventilation, the total number of patients was 1,053. 66.3% died. And same data, which included UK, Wales, and other part of the UK, that those patients who were not ventilated, out of 444 patients, only 19.4% died, comparing with those who required ventilation. Then what they did, this audit compared it with the viral pneumonia other than COVID-19, who needed mechanical ventilation during the year 2017 and 2019 to see that the viral pneumonia, how does patients' outcome if it is not COVID, those who required ventilation. And they found out the mortality was 35.1%. That is much lower than COVID-19 patients. This data supports other data. That means patients who required ventilation, who were put into ventilation for in intensive care unit. Also, data in Italy, Spain showed that those who were ventilated, their mortality is high. Even in USA, it showed a worse scenario. Patient given ventilation for respiratory support, their mortality rose up to 88%. So it was thought that the mortality is high. Nobody was aware, nobody knew what to do. Then came one very important person who is Luciano Gattuso. This renowned intensivist first pointed out to the whole world by later to American Journal of Respiratory and Critical Care Medicine. He wrote this letter on 30th March that the patients we are treating as a case of ARDS with the Berlin protocol is probably not doing any benefit, rather it is doing more harm. So he proposed that there are two distinct phenotypes of COVID-19 respiratory failure that is happening. Before I go into his explanation, I want to show you again this picture. As you can see, the air comes into the alveoli, it carries oxygen, and this is alveolar capillary. As you can see, this end is the pulmonary end of the alveolar capillary, and this is the venous end of the alveolar capillary. It comes very close contact with the alveolar endothelium, and this is vascular endothelium. So oxygen at the beginning diffuses into the alveolar capillary. As the blood passes through this tank, by the time it processes from this end to this end, the oxygen gets enough time to get into the blood and causes oxygenation of blood and carbon dioxide going out. Now, if anything, normally when there is viral infection and viral pneumonia, so there is a tendency of hypoxia. And hypoxia is a potent stimulus for pulmonary arteriolar constriction. And this hypoxic constriction is so important because by this constriction, actually the pulmonary circulation diverts the blood from less ventilated area to more ventilated area. This pulmonary vasoconstriction acts like a police or traffic police. They divert the blood to the areas where it is more ventilated, where is less ventilated area to more ventilated area. And this is very important for this maintenance of oxygenation. Now, if you see that this constriction, pulmonary hypoxic reflex constriction is absent, then what will happen? the blood will pass through this capillary and will go in a way that it cannot take oxygen from alveoli. So a situation will be created when blood shunts from this end to that end and oxygen is not diffusing enough to give the patient enough oxygen. So the patient will become hypoxic. Now, to get rid of this hypoxia, what can you do? Either you control the blood flow, which you cannot do. You cannot control the blood flow. Another thing you can do is to increase the concentration of the alveoli so that the more alveolar oxygen concentration, more chance of diffusing oxygen into the circulation for getting the blood oxygenated. That is Luciani Gattuni's proposed theory, and he said we need not to put patient like ARDS. We are actually putting the patient in high peak, high concentration, and we are injuring the lungs. And from that day, the total scenario of the world management of COVID-19 in ICU changed. And what he proposed? Gattinoni proposed that lungs are compliant and there is failure of hypoxic vasoconstriction that leads the shunting of blood in a well ventilated lung. That means the blood shunts rapidly from this area, oxygen cannot get enough time to diffuse. These groups of patients are maximum. Most of the cases who are hypoxic, I think 90 to 95% patients are hypoxic because of these mechanisms. That is, they are not ARDS patients. They are basically hypoxic because there is a shunt going on, blood is passing rapidly. So in these groups of patients, if you increase the concentration of oxygen into the alveoli and allow some time, keep the patient alive for 5 to 6 days, body will automatically take over. And so they said that high flow oxygen, continuous positive airway pressure, or BiPAP in extreme cases can be very helpful. Only ARDS management plan is needed only a small percentage of patients of COVID-19. So this needed to be understood by all of us, not only by all of us, also by intensivists who deal with the patient in ICU and who are putting the patient in ventilator. You must understand that these groups of patients are severely hypoxic, even though they are not patients of ARDS. In cardiovascular system, another important issue we need to clarify, which needs to be clarified and also understood by all the doctors, and that is renin-angiotensin system. Because there is a huge cry and view that there was a case report that in the Lancet, and there was a hypothesis proposed that since this virus infects ACE2 inhibitor, and this virus causes those who are taking renin-angiotensin system C inhibitor and ARBs, they are more vulnerable for severe infection. That is why I'm showing you exactly how we should interpret the situation. Normally, liver produces angiotensinogen is a protein. It is inactive protein, circulates abundantly into the circulation. The kidney has got a very, very sensitive detecting system. That is, any condition which, when there is a fall in blood pressure, immediately the kidney juxtaglomerular cells present in the afferent arterioles, they get signal because they have got sensors. It's like measuring machine, blood pressure machine. So each of the kidney has got roughly 2.4 million. So each of the kidney has got 2.4 million, literally speaking, blood pressure measuring machines. So whenever there is a tendency of blood pressure to fall, kidney causes immediate release of this enzyme renin. This enzyme acts on angiotensinogen and causes production of angiotensin 1. This angiotensin 1, by the action angiotensin converting enzyme, mostly in the pulmonary circulation, converted into angiotensin 2. Angiotensin 2 is a very potent actor. It acts on angiotensin 1 receptor. It causes vasoconstriction immediately throughout the body. Not only does for vasoconstrict, it also stimulates inflammation, fibrosis, proliferation. As a result, there occurs immediate rise of blood pressure. Not only that, it stimulates three bad effects: cardiac fibrosis, thrombosis, even sometimes AR disease. As I said, body needs a balance. There always has to be a feedback or a balance system which will counteract the action of one who will exert a deleterious effect. So body has a balance system like this. So angiotensin 2 with the influence of ACE2 enzyme is converted into angiotensin 1 and 7. Angiotensin 1,7. This angiotensin 1,7 is very important because it exerts just opposite action what is done by angiotensin 2. So it causes vasodilation, it causes anti-inflammatory, anti-fibrosis, anti-proliferation. So that's how angiotensin 2's action is balanced by the action of angiotensin A and 1 and 7, which is converted by ACE2. Now, what was the theory laid by the hypothesis which caused tension among the physicians whether to continue with the AC inhibitor or ARB is that ideally, if you look at the action of the antihypertensive drug, AC inhibitors, what does it cause? It causes angiotensin 1 to be converted into angiotensin 2. So there is less production of angiotensin 2 by AC inhibitor. And what ARB does, ARB causes inhibition of action of angiotensin 2 into its receptor. So ARB also inhibits the action of angiotensin 2. So ideally, AC inhibitor and ARB, by reducing the concentration of angiotensin 2, should be doing good job. But the hypothesis is for different thing. Not only they inhibit the production of angiotensin 2 or ARBs inhibit the action of angiotensin 2, they causes stimulation and upregulation of ACE2. Since the virus utilizes ACE2 as its entry into the cell, the hypothesis they gave that these two drugs, by increasing the availability of the ACE2 receptor, they are making the patients more vulnerable and making the person vulnerable for severe disease. That's why the whole world went into a serious study. And all these studies showed that there is no effect of these two AC inhibitor and ARB to cause aggravating or severe disease in patients who are COVID. So this is position statement of the ESC. This is American College of Cardiology. And finally, 7th May, WHO, meta-analyzing all the papers, they have concluded that ARB and AC inhibitors can be given without any hesitation. Now that point has been made clear by me. Now let us come back to the effect of the disease in cardiovascular system. As I said, whole of the body has got receptors, AC2 receptor, like endothelium of the coronary and renal vessels. So these receptors allow the virus to enter. Not only that, there is direct viral invasion of the heart. This viral invasion in the heart, together with hypoxia, cytokine storm, sympathetic overactivity, all this leads to myocardial injury. with type 2 myocardial infarction. This type 2 myocardial infarction means myocardial infarction occurring in absence of atherosclerotic cardiovascular disease. Not only that, these patients are very prone to heart failure, tachyarrhythmia, carditis, and even sudden deaths. So this is another important point. Those who are managing the cases not focus only in respiratory system, also keep a sharp eye on cardiac system. Another important killer is hypercoagulable state. This virus, as I said, that the virus, the vascular endothelium has ACE2 receptor. So virus can directly invade the endothelium. It can cause the inflammation of the endothelium of the arterioles, and this inflammation causes release of procoagulants, of which most important is von Willebrand factor and activated factor A. Once they are released, they initiate the cascade of procoagulation. So cytokine storm together procoagulants and inhibiting anticoagulants cause a state of hypercoagulability. And as a result, there is widespread thromboembolic complication of both pulmonary and systemic circulation. This is another important aspect. So we have to deal, when we deal with the patients of COVID-19, we keep in our head there are three immediate pillars. One is respiratory, one is cardiac, another is hypercoagulable state. If we address properly admitted cases, keeping in our mind these three things, then we will be more aware which system is dominating in which patient and causing damage. Further, as we know that the virus also causes viremia. So it starts when it starts in circulation, spreads in the circulation, it gives rise to systemic inflammatory response syndrome. Not only that, as it progresses, it may cause generalized vasodilatation, increased generalized permeability of vessels together with blood pressure, follow blood pressure, and septic shock together with multi-system organ failure. This is another complication which rare though but can happen. In kidney, frequently we get COVID-19 patient presenting with AKI, acute kidney injury. There are several factors thought to be contributing this, one of which is pre-existing CKD, together with septic and cardiogenic shock or virus directly invading the kidney and cytokines causing this acute kidney injury, which may require dialysis in the patients. In liver, same direct liver injury can cause release of hepatic enzyme, and hepatic enzymes is quite high, together with some patients may show evidence of hepatic failure. GI system, virus directly invades GI system, and it can cause nausea, vomiting, diarrhea. There is also loss of sense of taste and smell. Nervous system also involved by the virus, giving rise to stroke, seizure, Guillain-Barré syndrome, loss of consciousness, even in young patients. Those with pre-existing cardiovascular disease also may present with this CNS complication. Another complication which needs to be described is CRS, cytokine release syndrome, together with macrophage activation syndrome, hemophagocytic lymphohistiocytosis, which I think I'll discuss in management. Now we need to diagnose COVID-19 after we know the pathophysiology and disease progression. Diagnosis, the viral incubation is about 14 days, all of us we know, and average symptom starts by 5 to 7 days. Any new patient coming to you with onset of fever, cough, dyspnea, with or without exposure to contact, it doesn't matter. Now, community spread has already started and it has gone in exponential state. So, anybody coming with this symptom must be considered to be a patient of COVID-19. any unexplained pneumonia, any unexplained breathlessness, ARDS should be regarded as COVID-19. Not only that, at one point it was thought that children are spared from the viral disease, but now cases are coming. There are two distinct children presentations thought to be correlated with this virus. One is Kawasaki-like disease, another is toxic shock syndrome in children. Not only that, there are distinct 4 dermatological manifestations, which are generalized dermatological manifestations, can be sole presentation of COVID-19. So, any patient, even coming with generalized body ache, any patient presenting with diarrhea, with skin disease, new onset, you should suspect COVID-19 at this stage of time. For diagnostic test for diagnosis, there is only one gold standard test, and that is RT-PCR for SARS-CoV-2. This has to be done to confirm the diagnosis. Now, all the patients, everybody cannot be offered a diagnosis. So, diagnostic test has to be done on priority basis. This is very important. So, for priority basis, we can categorize the patients in 3 groups. Category 1, anybody who hospitalized with suspected COVID-19 must be diagnosed and get this test done. Category 1, symptomatic healthcare workers who are frontliners. Anybody having minimum symptom must be tested. Category 2, symptomatic long-term caregiver or symptomatic high-risk patients and first responders, like those ambulance workers, like those who are dealing with important activities in maintaining law and order situation. They are also symptomatic, they deserve to be tested. And finally, category 3 is critical infrastructure workers who are symptomatic, like WASA workers, electricity workers, or in a society, those who are having high burden of the disease. This is category 3. Outside this category, actually, we cannot offer this important test. Specimen collection, as we can see that everybody knows that now, most 2 important specimen samples contained are nasopharyngeal swab and oropharyngeal swab. These are the 2 standard samples to be taken. Besides that, expectorated sputum, nasal mid-terminate or nasal swab sometimes can be taken by patient himself to be disposed and delivered. And in ICU setting, when a patient comes undiagnosed and straight away goes to ventilator, his tracheal aspirates and bronchoalveolar lavas may be important for diagnosis. One important point must be emphasized, that about 30% of patients may show negativity. But if there is strong clinical suspicion, the test must be repeated, because sometimes it has been seen that second and third time tested came positive. So under circumstances, we may have to repeat the test. So what is the role of antibody test? Antibody tests are important to detect recent or past infection. Actually, all of us healthcare workers, those who are not exposed or those who are not shown symptoms to be tested, actually we should wait for an authentic antibody test to come. If we find ourselves that we have been exposed or we are having immunoglobulin specific to this virus, we would be able to understand that we have been exposed, although we were not symptomatic. So that will give us a epidemiological picture and reassurance that we can go back to work even though we did not show any symptom. But these tests, antibody tests, are not recommended for diagnosis of COVID-19. They should be done to detect the exposure of the virus. More than 20 antibody tests are available. Of them, only 4 tests got emergency use authority by FDA, CDC, and NIH. So SELEX, orthoclinical diagnostic, Cambio, and Mount Sinai. Besides these four company, if you see any other company coming with antibody proposals, they are not actually authenticated and validated. So there is a confusion whether you take that test as your to take it as an account. These four tests are under evaluation. Now, what are the pitfalls of this antibody test? Currently, it has been seen that in the first week, detectable antibody is less than 40%. So if you do antibody test at the end of the first week or the first week, you will miss 60% of cases. There is a chance. Not only that, there are claims that antibody, those who actually commercially produce, they want to show that their product is very good quality, but actually it has been seen to become significant antibody titer to be detected. The median time from symptom onset is 12 days for IgM and 14 days for IgG. So by that time it gives significant positivity. The days are elapsed 12 to 14 days. So acute diagnosis is not in for the management of the patient. Accuracy of the test varies with the kids. Specificity in broad population is lacking because there are concern of cross-reactivity. We know that in our community, human coronaviruses are prevailing. They regularly cause seasonal upper respiratory tract flu. So this human coronavirus may cross-react and give rise to false positive tests. IgM tests are prone to false positive, as I said before. Antigen test is very important. 8th of May in 2020, this month, Quidel Corporation got approval of antigen test for SARS-CoV-2. This device name is Sophia 2 SARS antigen FIA. It can be done at point of care and results can be given within 15 days. I have tracked this company and I have seen this company is shifting millions of their antibody test kits throughout the world. That means that the whole of the world kept an eye on this product and they pre-ordered this product for quick availability in their countries. In Bangladesh, I am not sure whether anybody aware of this development and whether they pre-ordered already to get the kit as early as possible, because this is actually the job of IDCR. They should actually track which tests are authenticated and which tests are being done, and they should inform the government and authority that we need to order early, because if it gets permission, we can get this kit very quickly for our population. So if we have missed it, we should immediately order this antigen kit. Now, one of the important point is management of this disease. So what I see that from the beginning, China divided the disease depending on its severity in 3 categories, and whole of the world accepted this division because more or less it helps in management of the disease. So they divided disease in the mild category, where there is no symptom or minimal symptom. 81% gets the mild disease. Severe disease, which accounts with dyspnea, hypoxia, and more than 50% involvement of the radiology, is about 14%. And critical disease, which presents with respiratory failure, shock, multi-organ failure, is only about 5%. These 3 categories of patients has to be managed. Now we have to see the risk factor for severe disease. Who gets severe disease? As I said in my previous slides, that immune system, innate and adaptive immune system doesn't work properly under certain groups of people who get severe disease. So these are the groups of people. Sometimes they don't get enough innate and antibody response and adaptive immune response, so they are at increased risk: cardiovascular, diabetes, hypertension, obesity, chronic lung disease, chronic kidney disease, cancer, and age above 65 years. How we manage these cases? Those who are asymptomatic and mild disease, they should be kept in home with isolation. Complete isolation, but stay at home with nutritional support. Just follow up. Patients should be given tips that if they get suddenly breathless, chest pain, any condition giving rise to increase in pulse rate, they should immediately report and come for hospitalization. Severe disease, when we consider it, when oxygen saturation is less than 93%, PaO2 is less than 300 millimeter, respiratory rate more than 25, or respiratory distress, and more than 50% involvement of the lung parenchyma on radiology. Anybody having severe disease should immediately hospitalize. Now, hospitals should have a dedicated COVID-19 management setup. Just a ward, a unit is not enough. Doctors cannot help this patient until they are supported by a very dedicated COVID-19 management setup. And each of the hospital who are dealing with COVID-19 patient, I suggest they should develop their own protocol depending on their resources and manpower and other technical availabilities. But all the hospitals should have 24 hours dedicated lab support, because you never know. A patient may needed to do troponin I at evening time. Someone may need to do NT-proBNP at midnight. So a 24-hour dedicated lab must be there. Dedicated ICU for COVID-19 patients, 24 hours availability of cardiac and renal team, because there is a fair chance anybody developing arrhythmia or near fatal arrhythmia should immediately be cardioverted, may even be needed to catheterize for this intervention to stop arrhythmias. So dedicated cardiac and renal team must be made available on call. Laboratory features which needs to be done on admission for every admitted case is this D-dimer, CRP. If it goes high, so this shows that severe disease. LDH more than 240, C-reactive protein more than 100, troponin I more than 2 times upper limit of normal, ferritin more than 500 micrograms per liter, CPK more than 2 times upper limit of normal, and ECG. Any ECG abnormality should raise suspicion of cardiac involvement, and decrease in absolute count of neutrophils also indicates that patient is having severe disease. Now, in hospital management of severe disease, there are 4 things any doctor, you have guidelines, you will find that there are big booklets. You don't have enough time to go and read all these booklets. So I make it very simple for you. Those who work in hospital, you keep 4 immediate response. That is response to hypoxia, open an intravenous channel and give it fluid as per needed. Then start empirical antibiotic. Some of the authorities might say that antibiotics should be given carefully. Well, that was academic discussion. But now you are treating the patient in hospital, you have to start empirical antibiotic and prevention and management of coagulopathy. These are the 4 things whenever you deal with admitted patient in hospital of COVID, you just remember these 4 things. Respiratory care, if they are respiratory. So I will discuss these 4 separately. Besides attending these 4, you just follow up the patient for next 3 things to happen. Management of cardiac emergency, treatment of multi-organ failure, and management of cytokine release, macrophage activation, or hemophagocytic syndromes, if it is there. So expect these not to happen, and if it happens, these three things happen so that you can actually take care of the patient. For respiratory failure, patients initially present with hypoxic respiratory failure. Target oxygen saturation is 92 to 96% in case of normal, and 80 to 90% in those patients who are COPD with carbon dioxide retention. Now, first of all, you will find patients who are hypoxic without breathlessness, without any breathlessness. So these are silent hypoxic patients. If you do pulse oximetry, you will find that they are hypoxic. So start with nasal cannula. Then if they still don't respond, 1 to 5, then 5 to 10, and use non-rebate mask 10 to 15 liter per minute. Usually this is sufficient. Then second category of patient, hypoxia with breathlessness. These groups of patients, when they fail to respond to this initial treatment, you give high flow nasal cannula, continuous positive airway pressure, or BiPAP. Usually they should be responding. So maximum patient response to these two maneuver. A small percentage of patients doesn't respond to this. Patient with severe respiratory failure, in spite of this management protocol, actually they may need to be ventilated. But it should be remembered that they should be ventilated with very low tidal volume. And as I said, intermittent prone positioning is very important, because when you prone the patient, it allows the basal part of the lung, alveoli, to be expanded, and that allows more area to be ventilated. Patient presenting with ARDS. As I said, very small segment of the patient presents with ARDS. Actually, they require mechanical ventilation with standard Berlin protocol. And these groups of patients may be benefited from ECMO, extracorporeal membrane oxygenation. But recently, I have seen that a paper that there were many centers enthusiastic of ECMO, but ECMO also is not doing very, very dramatic change. And intermittent prone positioning is also very important with these groups of patients. Another, I said that conservative fluid. That is, you open an intravenous fluid channel, but allow the patient to take IV fluid not more than 1 to 2 liter. Never overhydrate the patient. Just keep the patient in volume. And prevention of management of coagulopathy. This is very, very important. Anybody who got admitted with COVID-19 disease should be initiated with prophylactic low molecular weight heparin, irrespective of their D-dimer level, until there is contraindication. And contraindication is platelet count less than 25,000 or active bleeding. Dose escalation should be done based on D-dimer and patient's condition. Antibiotic, as we should be starting, because patients show consolidation and pulmonary shadows. So broad spectrum antibiotic with coverage of atypical pneumonia should be chosen. So choice between meropenem, monodram, IV 80 early, or piperacillin plus tazobactam. Either of these two should be chosen, plus one of these three, levofloxacin, bloxifloxacin, or doxycycline orally. Either any one of these three can be chosen from with this as a combination. Duration should be not more than 5 to 7 days. Treatment of multi-organ failure. One of the most important is heart. Heart failure can occur, acute cardiac injury, type 2, MI, and arrhythmias. All has to be monitored carefully, supported by echocardiography, NT-proBNP, and troponin I. And if patient gets any cardiac condition, immediately should be addressed. If patient gets septic shock or cardiogenic shock, that has to be immediately taken care of by appropriate protocol. Acute kidney injury should be followed up, and if needed, patient should be dialyzed. In hospital, so far I have discussed about the general management. Now, specific management, that means that giving medicine against, specifically against virus. There is no specific antiviral treatment yet today which can be confidently given. Drugs given are doubtful efficacy, but universally are tried throughout the world. I will name these drugs. First of all, hydroxychloroquine and chloroquine. Although there are several data not supporting the benefit of this drug, still, this is the fifth highest prescribed medicine in USA. Hydroxychloroquine is still today prescribed. Second drug is important is remdesivir. Recently, a paper randomized control trial proposed that this drug does cause some benefit, at least in terms of hospital stay. So recovery is a bit earlier with remdesivir, so it gives some benefit. It is thought so it can be given at an earliest when the patient goes down with severe disease, hospitalized. Convalescent plasma only used in severe cases, specifically those who are in ICU setting. And favipiravir can also be tried, but randomized control trial to support all these drugs to convince that must be given are not yet that much convincing. Cytokine release syndrome, macrophage activation system, hemophagocytic lymphohistiocytosis is another silent killer in COVID-19. There occurs cytokine release by the macrophages, uninhibited macrophages. These cytokines causes high fever, diarrhea, peripheral and pulmonary edema, circulatory collapse, cardiac, renal, and multi-organ failure, including coagulation cascades. So diagnosis, high degree of clinical suspicion should be there for the diagnosis of cytokine release syndrome or macrophage activating system. But most importantly, we can do C-reactive protein and ferritin. These two are important because if these two goes high, then this gives a reasonable confidence that cytokine release syndrome is occurring. So treatment, if you see that the evidence of cytokine release syndrome is there by very high C-reactive protein and very high ferritin, then only you should give tocilizumab intravenously in a dose 8 mg per kg. Repeat after 8 hours. Treatment should not exceed 4 doses. And this tocilizumab should be given with intravenous steroid, either hydroxycortisone, dexamethasone, or methylprednisolone. This is the only place where steroid is unequivocally advocated. Besides this, in other areas, steroid is not indicated. Treatment of macrophage activation syndrome and hemophagocytic lymphohistiocytosis, anakinra, IV 4 mg kg per day, twice daily in divided doses. So, how to differentiate these two? If you see C-reactive protein is very, very high, then it is more likely to cytokine release syndrome. If you see ferritin is very high, then you can suspect that there is macrophage activation system. But initially start with tocilizumab. If it does not work, then maybe you try anakinra. In conclusion, in the history of mankind, no other disease has had such impact in human life globally. The whole world has come to a state of almost standstill for last 3 months. Understanding COVID-19 is evolving every day. As research and management of critical cases are ongoing, scientists, doctors, internists, respiratory and critical care experts are facing completely unprecedented findings that cannot be readily explained by existing knowledge. So, if you every day you may feel you know enough about COVID-19. But practically, when you go to manage the patient, you will find you have not learned everything. And for COVID-19, every day is a new learning day. With these few words, I thank you all for patient hearing. I'm sorry, my slides are basically very nice. I don't know how this innovation took place in my slides and they showed automatic scratches, but I feel that you would be patient enough to listen to me, and I thank you for your patient hearing. So I will take it, I give it over to Sakline, who will moderate the session now. Sakline, you can come and take the question answer if there is any.
Thank you, sir. Thank you for your nice presentation. Actually, আমরা ঠিক সেই ঢাকা মেডিকেল কলেজের আমরা যারা স্টুডেন্ট ছিলাম অনেকে আপনারা স্টুডেন্ট অন্যান্য মেডিকেল কলেজও এখানে উপস্থিত আছেন। আমরা আসলে ঠিক সেই সময়টায় চলে গেছি যে সময়টা আপনার ক্লাসগুলো শোনার সময় আমাদের এক ধরনের পিন পতন নীরবতা আমরা খেয়াল করতাম। আজকেও আমরা ঠিক সেরকমই একটা স্মৃতি আমাদের কাছে আসলে এসেছে। থ্যাংক ইউ স্যার। প্রথম হলো আপনি সুস্থ থাকবেন এবং আমরা মনে করি যে আমরা এই ধরনের ক্লাসটা আরো করাতে চাই, আমরা করতে চাই। এই মুহূর্তে যারা আমাদের সঙ্গে অ্যাটাচড আছেন তাদেরকে একটু রিকোয়েস্ট করব যে আপনাদের যে কোয়েশ্চেন গুলো আছে আমরা ওয়েলকাম করব যদি আপনারা সেগুলো চ্যাট বক্সে দিয়ে দেন, কারণ আমরা কোয়েশ্চেন গুলো হয়তো বা সাউন্ড কোয়ালিটির কারণে, নয়েজের কারণে হয়তো বা সবার সরাসরি কোয়েশ্চেন নিতে পারবো না। তবে তারপরেও যদি কেউ চান যে আমি স্যারের সঙ্গে সরাসরি কথা বলবো, দেন ডেফিনেটলি উইল অ্যালাউ, বাট উইল এপ্রিশিয়েট যে আপনারা যদি আমাদের চ্যাট বক্সে কোশ্চেন গুলো করে থাকেন। আমি স্যার কিছু কোশ্চেন আপনাকে চালু করতে চাই। অনেকে অ্যাটাচড আছেন, আপনার ডিভাইসের স্ক্র্যাচ নিয়ে হয়তো বলেছেন, সম্ভবত এটি স্যার আপনার স্ক্রিনে হয়তো আপনার আঙ্গুলের টাচ পড়ার কারণে আমার মনে হচ্ছে এটি হয়েছে। বাট
আমি টাচ করিনি।
ও সো তাহলে আমরা এটা আসলে খারাপ লাগেনি, আমরা এনজয় করেছি আসলে স্যার। স্যার একটা কোশ্চেন আমরা ফার্স্ট কোশ্চেন নিতে চাই। প্রফেসর ডক্টর মোহাম্মদ তৌফিকুর রহমান, most probably. We are seeing some of our reputed seniors are dying from COVID-19, diagnosed or non-diagnosed. Can we prevent their death? Is there any role of prophylactic anticoagulants in those very senior people who are less mobile and more prone to develop thrombosis and its complication? স্যার আমি জাস্ট একটা কোশ্চেন সাথে অ্যাড করে দিই, আরেকজনও করেছেন। তিনি বলেছেন যারা হোম কেয়ারে আছে থ্রম্বোপ্রোফাইল্যাক্সিস কি তারা নিতে পারবে কিনা, যেহেতু থ্রম্বোএম্বোলিজমের একটা ভয় তারা কাজ করছে। দুটো কোশ্চেনে একসঙ্গে একটা অ্যানসার চাই আপনার কাছে।
Exactly, fantastic question. I think these are the questions who needs to be addressed. I suggest that even minimum symptomatic, those who are at home care, but those who are at high risk, I suggest even at home, they should be started with thromboprophylaxis. But one important thing I must emphasize that those who are direct acting oral anticoagulants, they are not recommended. Even if home setting under supervision of a doctor, patient, those who are at high risk should be started with prophylactic low molecular weight heparin. But remember, these patients has to be RT-PCR positive COVID patients, and they are old, frail, high risk groups of development of hypercoagulable state and thromboembolic risk. Of course, they should be given at house setting, home setting.
Sir, next. Okay. Another question is ivermectin act in which steps? His name is most probably Poco. So he was asking ivermectin act in which steps?
You see, there was a lot of enthusiasm with ivermectin. The reason behind it, there is a group in Australia, they studied in their laboratory and they found out that ivermectin can inhibit SARS-CoV viral growth in vitro. And recently there were in television, I think, some from USA, one doctor has given his personal experience that he has given ivermectin, and everybody got cured. There is no scientific basis of giving ivermectin and curing the patient. You see, I showed you there are 4 authentic drugs which at present are practiced throughout the world. And in this, ivermectin has not been yet scientifically advocated for every patient.
Thank you, sir. Some praise is there. Excellent presentation and information, Dr. Nur Hussain Bhuiya from Ashraful Jaman. Thank you very much, Professor FM Siddiqui. It's amazing. অনেক প্রশংসা আসলে স্যার আমরা সবগুলো দিতে পারছি না। Another সুস্মিতা হোসেন, প্রায় 15 বছর পরে আপনার ক্লাস করছি স্যার। Absolutely mesmerized.
Sushmita, give my regards. Yes, I can remember.
Professor Mohammad Asadul Kabir, excellent presentation. Actually, a lot of questions is there from ivermectin. I think Sumaya Shafiq, we already go through the role of ivermectin. And from Mahruzuba, record চাচ্ছেন, আমরা আশা করি যে এটি আমরা রেকর্ড প্রোভাইড করতে পারবো later and we will organize to
এবং আমরা এটাকে একটা ভালো আই থিংক একটা ভালো স্লাইড আমরা দেওয়ার চেষ্টা করব। আমি জানি না টেকনোলজি পারমিট করবে কিনা।
স্যার আমরা শুধু ভালো স্লাইড না, আমরা রিপিটেডলি আমরা চাই যে প্রতি সপ্তাহে আপনার একটা করে ক্লাস থাকে। সো আই থিংক আমার রেকর্ড লাগবে না স্যার, এবং আপনাকে আমরা আসলে আবার বের করে নিয়ে এসেছি। সো আপনাকে স্যার আর আপনারা রেস্ট।
I must say everybody that my presentation আজকে আমি যেটা রেডি করেছি, the initiator is Sakline, man, he found me out after একজন থার্ড পার্টি দিয়ে ধরে সে আমাকে ফোন করে, তারপরে he pushed me to come up with, because আমি ওকে বলছিলাম যে দেখো ভাইরাস এক্সপার্ট বাংলাদেশে এত দেখতে পাচ্ছি, then how many can get benefit. Actually আমার এই intention of this lecture is to make a foundation. I try to address the areas which has not been clearly addressed. Hypoxemia কেন হয়, কেন পেশেন্ট গুলো ভেন্টিলেটরে মারা যাচ্ছে, ভেন্টিলেটরে দেওয়া মানে একটা ডেথ সেন্টেন্স, like ICU তে ঢুকা মানে ডেথ সেন্টেন্স, but if it is properly managed even at severe stage. Now you see that in America তে একসময় ভেন্টিলেটর নিতে হিউজ ক্রাই হয়েছিল, এখন কিন্তু ভেন্টিলেটর নিয়ে আমেরিকান ডাক্তাররা আর কোনো হইচই করছে না, বিকজ ম্যানেজমেন্ট স্ট্র্যাটেজি চেঞ্জ হয়ে গেছে টোটালি, রেসপিরেটরি ফেলিওর ম্যানেজমেন্ট completely changed, and mortality has been reduced significantly even in ICU setting. Another is those patients who are recovering 80%, they are coming in the social media with bizarre ideas. That is COVID-19 winners. They come with different pots, different things, how they inhale this, how they taken sips of water every minute and everything. This is no scientific. It didn't do, you don't have to do anything like that, because I clearly mentioned your immune system took care of it carefully. That's why you got recovered. This is plain and simple. One thing is important, Sakline, that one should, this innate immune system is based on your ability of physical activity, exercise, and proper health and food and nutrition. So this is very important to keep oneself healthy, to make his innate immune system very potent and active.
Thank you, sir. Actually, আমরা নেক্সট যে প্ল্যানগুলো রেখেছি তার মধ্যে একটা হচ্ছে যে আমরা একটু স্পেসিফিক ওয়েতে স্যার লেকচারগুলো করতে চাই, যেমন ম্যানেজমেন্ট অফ কোভিড-19 পেশেন্ট, জেনারেল ম্যানেজমেন্ট, ক্রিটিক্যালি ইল পেশেন্টস গুলোকে ম্যানেজমেন্টের ক্ষেত্রে কি, প্যাথোফিজিওলজি অফ কোভিড-19 কি, এবং লেটেস্ট আপডেট, এরকম আমরা সেগমেন্ট ওয়াইজ আসলে নেক্সট টাইম আমরা স্যারের ক্লাসগুলো অ্যারেঞ্জ করার জন্য চেষ্টা করছি। নেক্সট কোয়েশ্চেন ফ্রম পিজু সাহা, all patient with COVID-19 should we give low molecular weight heparin 5 to 7 days, then maintaining days which drug we should use? তিনি যে কোশ্চেনটি করেছেন আমার মনে হয় স্যার আপনি ধরতে পেরেছেন।
এটা তো অলরেডি আমি একটু উত্তর দিয়েছি যে those who are at high risk, even those diagnosed at home, they should be initiated with low molecular weight heparin, and those who are severe disease, even after recovery and discharge, at least 2 to 4 weeks, they should continue their low molecular weight heparin. But if they come out of danger, I think later part of the maintenance, they can switch to oral antihypocoagulants after 2 weeks of low molecular heparin after recovery.
Okay, nice, sir. Next question from Dr. Fatima Farhana. How to, if a pregnant mother become infected, then what management and advice should be given to her?
She should be managed exactly the way other COVID-19 patients are being managed. Look at her severity of the disease. If she is mild and minimally symptomatic, she can be kept at home setting. But this is very important that pregnant mothers, if they become symptomatic, at least for 1 to 2 weeks, they should be kept in hospitals so that any emergency occurs, multidisciplinary specialists can come and try to manage her condition.
Thank you, sir. Another question from another question from Piju Shaha is is there any role of corticosteroids in IV form? And the question is from Mr. Piju Shaha.
Well, corticosteroids doesn't do any good, rather it can do harm. Only time you can give steroid is when there is specific cytokine release syndrome proven. Only then you give steroid intravenous together with tocilizumab. Otherwise, role of steroid is there is no benefit giving steroid, rather you might do harm. Another point of giving steroid that is allowed is when patient is in severe shock and all the treatment plan fail to recover the patient from shock stage. That circumstance, steroid low dose can be tried, whether the blood pressure can be raised or not.
Nice one, nicely. And another from Dr. Nahida Jafrin. What is the management of COVID-19 in diarrhea?
Well, you just manage the fluid and electrolyte balance. I mean, if there is uncontrolled diarrhea, then intravenous fluid, which we usually use in diarrheal patient, that is, there is no such no difference in management of diarrheal patient with COVID-19 other than managing like any other cases, because these diarrheas are self-limited. They don't persist more than 5 days, 5 to 7 days maximum. So nutrition and fluid balance, no specific antibiotic is indicated for COVID diarrhea.
Sir, lots of token of love for you there. Dr. Jakia Sultanullah, you're another student. It's very nice one and informative. Another from Saleh Muhammad Ali, just online. All the students of medicine in this country have missed your teaching for years. আমার মনে হয় যে আপনি বলার আগে স্যার আমি বলে দেই আর মিস হবে না। আমরা ডিজিটালি স্যারকে ধরে রাখার চেষ্টা করেছি। আমার স্ট্যাটাসটা হয়তো অনেকে দেখেছেন যে স্যারকে মারা যাওয়ার আগে আমরা মারা যাওয়ার আগে স্যারকে আমরা ডিজিটালি কালেক্ট ধরে রাখবো ইনশাআল্লাহ। স্যার প্লিজ।
Inshallah, thank you. Okay, যেগুলো মানে I can see the Adnan Yusuf. He's being with me from the beginning, and thank you, Adnan. And the names, Saklan, you were telling, I just feeling like I went back to my Dhaka Medical College time. So really, it is interactive and nice. I must give you thanks that you pushed me to come up with this presentation.
And inshallah, it will continue, sir. Definitely, we will continue. So now everything is digitalized. So why we not? Nice presentation from Kazimran Hussein Onirban. Excellent presentation. Sanjida Mahmood, thanks, sir. Aminul Islam, thank you very much. Sorry, some interruption is there. Yeah. Thank you, sir, for your nice presentation. Lots of actually thanks, sir. Apnar. Another Rebecca Tarannum, sir, apnar student, Sorashari, sir. রেবেকা তারা সে লিখেছে
Taranno
মোর
Rebecca.
ক্লাস, নিড মোর ক্লাস। আমরা সেটাই বলছি যে অনেক আছে। ডক্টর জাকিয়া
Give
সুমন আমার
Jackie, Rebecca, they are just like, still I remember after all these years.
এবং
So
তারা বলতেছেন
see, I can remember by their name.
জি স্যার, অ্যাকচুয়ালি তারা বলছে যে মনে হচ্ছে লেকচার গ্যালারি 1-এ আছে এই মুহূর্তে।
Thank you. I mean,
Dr.
I have
Shumon
feeling.
Kanti Chaudhary, thank you sir for your as usual nice lecture. Take care. Sanjida Mahmood waiting for the next session. Within 3 to 4 days you will get another session inshallah. Maruf bin Habib, question regarding use of convalescent plasma. As you have said that it is to be given in severely ill patient, means the patient has already passed at least 7 days where viremic phase is quite over. Will it work at that point where immune
Yes.
mediated damage of the body is
Mm.
taking upper hand in comparison to viremia?
As I said in the pathophysiology, you see, you will have to understand this part of the pathophysiology. Viremia dies down in 80% of cases. So there is no shedding of virus in 80% of cases, those who gradually recover. But a certain groups of patients who goes into severe disease in critical phase, as I mentioned, that innate and adaptive immune system is not sufficient enough to kill the virus. So there continues to be a phase when the virus probably is still multiplying at low dose level. And this may be one explanation. And there is also data showing that severe D patient, those who are given this plasma is actually convalescent plasma, showing some benefit. So probably they work by active, still surviving viruses, and maybe some other mechanism yet to be understood. But they have some benefit, there is no doubt.
What advice should be given to patients taking DMARD like MTX and others?
All the patients, those who are taking DMRD, those who are taking steroids for some reason, which is their maintenance treatment, should continue with all those medicines until and unless at some point some specialist feels that it should be stopped temporarily, but they should continue with these medications. There's no need to stop DMARDs and even low dose steroids who are taking it for long.
Anirban, started doses of low molecular weight heparin. উনি আসলে started dose-টা স্যার জানতে চাচ্ছেন low molecular weight heparin এর ক্ষেত্রে।
এটা তো আমরা we usually give in a dose of 42 subcutaneously standard dose যেটা সেটাই দিয়ে দেবো। এটা তো
স্ট্যান্ডার্ড যে ডোজটা। ওকে, আরেকজন খুব প্রশংসা করেছেন, অনেকবারই আমরা দেখছি, ডক্টর সাব্বির আকরাম সিয়াম। আলহামদুলিল্লাহ, থ্যাংক ইউ সো মাচ স্যার, অনেক অনেক দোয়া রইল স্যারের জন্য, সিয়ামের জন্য স্যারের পক্ষ থেকে নিশ্চয়ই দোয়া।
হ্যাঁ, আমার পক্ষে দিয়ে দেওয়া।
Sir, another question, same question is there. Fatima Farhana Mo, Dr. Fatima Farhana Mo, probably you can remember her name. Thank you, sir, for your excellent class. Another, yes, sir. Nice question, sir. This is our question also. Mr. Amir Hussain, what about prophylaxis for suspected healthcare workers, patients?
There is a study taken by a authority. They are ongoing with a prophylactic study of hydroxychloroquine, and they have recruited, as far as I know, around 85,000 workers, first liners and others. The study is ongoing. And so, because the study with prophylactic hydroxychloroquine is ongoing, this means that they are giving it to healthcare workers, frontliners. So, giving those who are at risk of exposure of COVID-19 high, it is quite rational to start prophylactic hydroxychloroquine with zinc. I would suggest that hydroxychloroquine has to be taken with zinc because zinc is a ionophore. Hydroxychloroquine, in its one step of its mechanism, it allows the zinc to enter into the cell to cause inhibition of the replication of the virus. So there is some role, but randomized control trial is still going on. I cannot give an opinion, but I suggest that hydroxychloroquine can be taken as prophylactic until the RCT report is coming out.
Dr. Nahida Jafrin, best pathology explanation of COVID-19 ever.
Oh, thank you, Nahida.
From Salma. Salma, the question is, should we give prophylactic antibiotic to all hospitalized patients?
Yes. You see, it is like that why you will refrain from not giving the antibiotic. The duration of stay of the patient in severe state is going to be 4 to 5 days. If you can keep the patient from disease severity going into the state to go to ICU, then patient is highly likely that he will recover and go home. And that 5 to 7 days period of time in our country, where there is chances of infection are so high, then why not we will give when the lung in itself is being damaged, and we know that when there is a viral infection damage, there is a fair chance of bacterial infection can occur. And what benefit you get not giving antibiotic?
আমরা খুব শীঘ্রই স্যার আসলে শেষ করতে চাই, তার আগে দ্রুত কিছু কোশ্চেন নিতে চাই। ডক্টর মাহমুদ হাসান মুন্না তিনি লিখেছেন আসলে স্যার প্লাজমা থেরাপির ব্যাপারে জানতে চেয়েছেন। স্যার আপনি কি এটা ব্যাপারে কিছু বলতে চান নাকি আমরা আগের বলাটাই ধরে নিতে চাই?
আমার তো মনে হয় অলরেডি বলা হয়েছে।
আমরা বলেছি, আমরা সেই জন্য সেটাতে যাচ্ছি না। একই কোশ্চেন আমরা আবারও একটা পেয়েছি, আমরা এটা রিপিটেশনে যাচ্ছি না। বাহাউদ্দিন স্বপ্নবাজ, থ্যাংক ইউ স্যার ফর দ্য নাইস প্রেজেন্টেশন, অলসো সাকলাইন ভাইয়া ফর দিস অ্যারেঞ্জমেন্ট। স্যার আমাকে প্রথম একজন থ্যাঙ্কস দিস স্যার।
ওকে, থ্যাংক ইউ। মানে তুমি তোমাকে অলরেডি দিয়ে রেখেছি সবাই। হ্যাঁ।
ফারহাদ তাসনিম উনি চেয়েছেন স্যার মেকানিজম অফ রেমডেসিভির এবং হাইড্রোক্সিক্লোরোকুইন চেয়েছেন স্যার। আমরা মনে হয় এটা আরেকটা ক্লাসে এটা এক্সপ্লেইন করতে চাই।
নাইসলি এক্সপ্লেইন করে দেব। এটা রেমডেসিভির আর হাইড্রোক্সিক্লোরোকুইন এটা খুব ভালোভাবে এক্সপ্লেইন করা যায়।
ডক্টর পিজুর সাহা স্যার জানতে চেয়েছেন আবারও ওনার আরেকটি কোশ্চেন, যে উনি ভিটামিন ডি রোলটা জানতে চেয়েছেন ইমিউনিটি বাড়াতে। স্যার আমার মনে হয় যে এটা আরেকদিন আমরা করতে চাই।
খুব শর্ট বলে দেই যে there are few things already proven by different research works. Vitamin D has got beneficial role in innate and boosting the immune system. So it should be taken nowadays, especially when there is prevalence community transmission of COVID-19. So vitamin D should be taken by most of us, those who deem that their vitamin D level is quite low or suspect that it's low.
বিশেষ করে যারা আমার মতো কালো আছেন তারা প্রত্যেকে এটি নেবেন, কারণ কালোদের স্কিন ভেদ করে ডি সহজে যেতে পারে না, ঘাটতি অনেক বেশি থাকে, আমার সিভিয়ার ঘাটতি আছে। আসসালামু আলাইকুম স্যার, ডক্টর তানভীর মাহাতাব, ইফ এনি পেশেন্ট ফাউন্ড অ্যাসিম্পটোমেটিক বাট COVID-19 পজিটিভ at that time, if he need any medication, পজিটিভ কিন্তু সিম্পটম নাই, কোনো ট্রিটমেন্ট স্যার চাচ্ছেন আর কি।
Supportive treatment means কোনো symptom নাই, that means that he actually should keep himself observant. But if he is in a risk group, then actually he should take more care, because you see there is no specific definitive treatment. So asymptomatic, why you would take some medicine other than isolating yourself and just stay home, get proper nutrition, fluid electrolyte balance, that's it. You don't need to take medicine.
Another good question from Samira Rahat Afroz, RT-PCR negative but clinically COVID-19, when to start low molecular weight heparin?
Immediately start if the patient is showing severe disease. And there is specific category I have already mentioned. You will find in my lecture that there are criteria set which designates a patient as a severe disease. Any patient who is symptomatic, having hypoxia, having lung involvement evidence, having respiratory distress. So there is set criteria. Even if it is RT-PCR negative, you start low molecular weight heparin. No problem. That is
অনেকে
more beneficial than harm.
স্যার আসলে অনেকেই কোশ্চেন করেছেন, আমরা কি স্যার এখন তো 12টা ক্রস করেছে, আপনি কি আমাদেরকে আর কয়েক মিনিট অ্যালাউ করবেন স্যার?
Definitely, no problem. To me, as long as you are there, I am available.
আমার তো স্যার আসলে অফ করতেই ভালো লাগছে, মনে হচ্ছে আমার তো অনেকগুলো কোশ্চেন আছে স্যার, এগুলো কোশ্চেন তো শেষ হবে না, এগুলো পুরো আমরা পর টেলিফোনে স্যার ছেড়ে নেব যখন আপনি এক্সারসাইজে বের হবেন স্যার। জানতে চাইছেন তানিয়া চৌধুরী, তিনি হোম ম্যানেজমেন্ট এবং মাইল্ড মডারেট ডিজিজের ক্ষেত্রে হোম ম্যানেজমেন্টের সম্পর্কে একটু স্পটলাইট চেয়েছেন, যে আপনি একটু স্পটলাইট দেন হোম ম্যানেজমেন্টের।
Home management, asymptomatic mild moderate disease. So home management means the patient, assuming that the patient is having fever and cough. So these two symptoms are prevalent. So when there is fever and cough, ideally patient should be under advised by nearby doctor from over telephone. Over telephone, that patient should be always in advice from a doctor. And what a doctor should do, he should, besides giving antibiotic, if possible, making some arrangements so that a pulse oximeter can be made available for the patient, so that he can see his pulse oxygen saturation. This should be made available, and so there is some means by which he can measure his blood pressure. Now, regarding treatment, these groups of treatments, when if this fever and cough is more than 5-6 days, I would recommend that we should start with an oral antibiotic, and that is best treatment would be to start with doxycycline in a dose of first day 100 milligram twice daily, then from next day 1 capsule daily for next 4 to 5 days. This is the first choice antibiotic. Then you can also start levofloxacin 750 milligram once daily, or moxifloxacin 400 milligram once daily. So these antibiotics should be kept in cover. Question is whether you should give the patient hydroxychloroquine in a dose which usually is advocated you give or not. If the patient is relatively young and patient doesn't have any cardiovascular disease, you can easily start to antibiotic together with hydroxychloroquine, because chances of harm is less than chances of benefit. So short course hydroxychloroquine together with antibiotic can be started.
স্যার আরেকজন আপনার খুবই কাছে থাকা স্টুডেন্ট এবং এই মুহূর্তে সে একজন কোভিড ফাইটার, একটি কোভিড হসপিটালের কনসালটেন্ট হিসেবে কর্মরত আছেন, নাম বললে আপনি এক বাক্যে চিনে ফেলবেন, ডক্টর হাসান শাহরিয়ার কল্লোল। স্যার
কল্লোল front fighter.
Yes sir.
He's a renowned surgeon.
Yes sir.
I would like to take কল্লোল তো আমার yes, is very close student, like Sakliner. There are few.
জি, এবং আমরা তো স্যার আবার জি
কত কল্লোলে কোনো প্রশ্ন নাই, ও তো নিজে
একটা কোশ্চেন আছে স্যার, একটা সে কারণে আমি জিজ্ঞেস করতে চাই। Sir, it was excellent to hear you after long. I want to know about setting up a COVID unit. What segment of doctors should be treating the COVID patients? Who specialty doctors should be in charge? And your thought on COVID versus non-COVID hospital or COVID unit at every hospital? It's a big question actually, sir. আরো 108টা কোশ্চেন আছে, আরো 108টা কোশ্চেন আছে। আমরা তারপরে আপনি জানেন যে কতজন আপনারা এই মুহূর্তে ক্লাস করেছেন?
না আমি আসলে কয়জন পার্টিসিপেন্ট আমাকে বলুন তো টোটাল।
আচ্ছা, আমি 292 জন পর্যন্ত কাউন্ট করেছি। এই মুহূর্তে কোশ্চেন এন্ড অ্যানসার সেশনে 200 জনের উপরে আছেন স্যার।
আলহামদুলিল্লাহ, this reflects যে মানে absence for 12 years did not make me deleted from the heart of those who are there. And you played a great role, and of course I thank Serbia. Actually, if I could not have get the support Serbia, especially Adnan Andali has given me tremendous support to make this. Only I am frustrated. I made so nice slides, Saklan, you would not believe. And when I saw that they are cracking in the screen, I simply felt deserted. But this is how life goes on. We can't really help it. And চাঁদেরও তো কলঙ্ক থাকে, সবকিছুরই একটা সমস্যা থাকে। সো সবকিছু যদি পারফেক্ট হয়ে যায় তাহলে তো আর হলো না, আমাদের নিজস্ব কিছু ট্র্যাক থাকতেই হবে, তা না হলে হাউ ক্যান উই গেট দ্যাট যে আমরা একদম সবকিছু এক্সেলেন্ট করে ফেলবো, তা তো হয় না। বাট যদি সবাই বুঝে থাকে, what is your impression, Saklan? Did you understand what I say? Especially pathology গুলো যেগুলো describe করার চেষ্টা করছি, foundation is the pathology, understanding the viral replication, its cycle, human cycle, and also understanding how it is causing the damage. Because এই দুইটা বুঝতে পারলে, when you manage the patients, you can in which stage these patients are playing. So this is very important. এসে একজন বলল যে we have found out a drug which inhibits RNA dependent RNA polymerase, then it inhibits the exocytosis of the virus. So actually what happened, remdesivirটা কেন একটু গণায় ধরা হচ্ছে, you imagine যখন এইডস পৃথিবীতে এসেছিল তখন কিন্তু কয়েক বছর কোনো মেডিসিন ছিল না, ভ্যাকসিন তো আজ পর্যন্ত হয়। সো তখন প্রথমে একটা ড্রাগ পাওয়া গেল যেটা কিছুটা কাজ করে, এইটার উপর বেস করে তখন কম্বিনেশন অফ অ্যান্টিরেট্রোভাইরাল থেরাপি আসে। নাও দ্য অ্যান্টিরেট্রোভাইরাল থেরাপি has become so efficient, patients with AIDS leading almost normal life, no reduction of life expectancy in AIDS patients. Can you imagine? Because of this combination of treatment. So this remdesivir probably, although it's not that working, but it is laying down a foundation. Based on this foundation, I think there will be multiple medicines which will be acting on different sites, from entry up to the exit of the virus within the cell. So there will be combination that has to be.
থ্যাংক ইউ স্যার। আমরা স্যারের ডক্টর হাসান স্যারের কল্লোলকে থ্যাংক জানাতে চাই এবং আবার নন কোভিড এবং কোভিড হসপিটালের সেটআপ নিয়ে
কল্লোল গান গায় কিনা এখনো জিজ্ঞেস করে বলতে হবে।
স্যার কল্লোল এখনো গান গায় স্যার, কারণ কল্লোল আমার আরো এক জায়গায় কলিগ, একজন নিউজ প্রেজেন্টার হিসেবে সে আবার আমাদের নিউজ প্রেজেন্টার সোসাইটির অ্যাডভাইজার টু প্রেসিডেন্ট। সো আমরা গান এখনো শুনি স্যার। স্যার 112টা এখনো নতুন মেসেজ আছে, আমি জানি না এগুলো সবাইকে পারবো কিনা, আগে ক্ষমা চেয়ে নিচ্ছে। একই সঙ্গে আসলে সার্ভিয়ারকে ধন্যবাদ জানাতে চাই পার্সোনালি, আমি তারা শুরু থেকেই একাধিক ক্লাস আসলে স্যার এইভাবে আয়োজন করেছেন, যখন যে বিশেষজ্ঞকে নিয়ে আসা প্রয়োজন তারা আসলে আমাদের সবসময় টেকনিক্যাল সাপোর্টটা দিয়েছেন, অর্গানাইজ করেছেন। সো অ্যাগেন থ্যাঙ্কস ফ্রম আওয়ার সাইড এবং থ্যাঙ্কস টু সার্ভিয়ার। হোয়াট ইজ আগে আমরা একটু যাই, কেমোপ্রোফাইল্যাক্সিস সম্পর্কে জানতে চেয়েছেন আহসান হাবিব। প্লিজ সে সাম ওয়ার্ডস অ্যাবাউট কেমোপ্রোফাইল্যাক্সিস।
Chemoprophylaxis means that those who are at increased risk, tara prophylaxis নিতে গেলে, I think I have already discussed Saklan, and that hydroxychloroquine is being in trial. It is in trial in long population. So let us wait and see.
Okay, sir.
What the result comes.
Dr. Srivash Paul, thank you, sir, for a nice and elaborated but very easy to understand presentation. Really, it will be a very good foundation.
Give my thanks to him. That's at least he understood, because I was confused that those who are listening actually getting inside it not. I made it in such a way that it doesn't look complicated if you follow from the beginning. If you bring someone in the middle, late phase, you will see the picture and will say, oh my God, what is this? So, but if you follow from the beginning, you will understand, no, it looks complicated, but it's not that complicated.
স্যার আমি একটু জাস্ট সংক্ষেপে কোশ্চেন গুলো নেওয়ার চেষ্টা করি। একটু
No,
জানতে চাচ্ছি যে মাইল্ড এন্ড অ্যাসিম্পটোমেটিক কেসে কি প্রোফাইলাক্সিস দরকার আছে কিনা, অ্যান্টিকোয়াগুলেন্ট থেরাপি দরকার আছে কিনা মাইল্ড এন্ড অ্যাসিম্পটোমেটিক কেসে?
mild and asymptomatic case, very elderly person, having hypertension, having diabetes, and other risk factors, yes, should be given prophylactic more low molecular weight heparin.
Okay, thank you, sir. Another question from Srivash Paul. Yeah, I have one question already. I think you have answered the question. I have one question. Should we avoid ACE or ARB in COVID patients?
No,
Yes.
I think that part, Saklan, did you understand that
Yeah.
when I described the
Yeah,
confusion
exactly.
regarding COVID-19,
Yeah.
did you understand? If you understood, then
Yeah.
don't try to make me happy. Just say, as you could have said in my
স্যার
class.
আমরা বুঝেছি বলি কোশ্চেনটা আবার নিলাম যে এটা কোশ্চেনের অ্যানসারটা আসলে আগে আপনি
ঠিক
করে
আছে, because
কোশ্চেনটাও দিয়ে
এই
দিয়েছেন।
প্রশ্নটা কিন্তু repeatedly being asked. That's why I took it deliberately, and I showed that there is no harm so far taking AC inverter ARB.
Another স্যার মানে কোশ্চেন আছে ডক্টর কেয়াদার স্যার, কোশ্চেন না ঠিক থ্যাঙ্কস দিয়েছে অন বিহাফ অফ ফ্রেন্ডশিপ ঢাকা। অ্যাকচুয়ালি স্যার আমাদের একটি সংগঠন আছে ডিএসডি এর নামে, ওখানে আসলে ডেসপারেটলি সেকিং ডক্টরস এর পক্ষ থেকে আসলে প্রায় 1,71,000 রোগীকে আমরা স্যার প্রতিদিন গড়ে 965 জনকে বিনামূল্যে চিকিৎসা সেবা দিচ্ছি কোভিড
My
19।
goodness, my goodness. Oh, nice.
ওটা স্যার চিফ অ্যাডমিন আর কি, এবং ডক্টর কেয়াদাস চিফ অ্যাডমিনেটর। এবং
Okay, give my best regards to her. These are the people who are really doing great job. তোমরা যারা এই young generation যা যা করছো, absolutely mind blowing. আমি মানে তোমাদের এই অ্যাক্টিভিটি গুলো আমি কল্পনা করতে পারছি না যে ডাক্তাররা কত ডাইভার্সিটি তাদের মধ্যে আছে এই ক্রাইসিসের মধ্যে। It's really came out. এবং real heart, real soul to help, selfless হেল্প করা মানুষের জন্য, মানে কিভাবে ঝাঁপিয়ে পড়েছে মানুষের ট্রিটমেন্টের জন্য। Sometimes although I have exceeded 60, I feel like I go stand by your side. I feel like কিন্তু হয়তো আমার মানে আমাকে আর এখন ওইভাবে অ্যাকোমোডেট করার স্কোপ নাই, বাট যদি অ্যাডভাইস দিও আমাকে করা যায়। But anyway, I'll be happy to be there anytime,
Sir,
anybody, any institution wants
স্যার
to.
ডক্টর সারোয়ার জাহান সবুজ, সে আসলে একটা আমাদের ডিএসডি এর একাডেমি নামে একটা একাডেমি আছে যেখানে আমরা স্যার ইয়াং ডক্টরদেরকে বিভিন্ন লেকচার দিয়ে, বিশেষ করে আপনার মতো যারা স্বনামধন্য ওয়ার্ল্ড ক্লাস লেকচারার আছে তাদেরকে দিয়ে আসলে স্যার আমরা লেকচার দিই। সেই ডিএসডি এর একাডেমি এর একজন কোঅর্ডিনেটর ডক্টর সারোয়ার জাহান সবুজ সেও আপনাকে স্যার থ্যাঙ্ক জানিয়েছে। লিঙ্কন স্যার আপনার স্টুডেন্ট আরেকজন পাওয়া গেছে স্যার, ডক্টর জুনাইদুর রহমান লিখন। সে লিখেছে স্যার, ইউ আর অ্যাজ ইয়াং অ্যাজ উই স অ্যাট আওয়ার স্টুডেন্ট লাইফ।
That gives a lot of encouragement. Good.
বজলুল গনি ভুইয়া, থ্যাংক ইউ ভেরি মাচ। প্রফেসর সিদ্দিকি ভাই,
Vijay Goni Bhuiya, yes, he's vascular surgeon. Saklan, you should know him.
Yeah, sir.
Yes.
উনি আমার একজন অ্যাডভাইজার বলতে পারেন স্যার, উনি আমার একজন অ্যাডভাইজার বলতে পারেন এবং আমার এগিয়ে যাওয়ার পথে ওনার অবদান অনেক স্যার।
He is a very good soul. খুব ভালো মানুষ and good teacher. Good surgeon.
এবং ডক্টর শ্রীবাস পলের একটা কোশ্চেন আছে যে হোয়াট প্রিকশন উই ক্যান টেক ফর ল্যাকটেটিং মাদার হু ইজ কোভিড পজিটিভ টু প্রিভেন্ট ইনফেকশন টু হার চাইল্ড। খুবই সেনসিটিভ এবং ইম্পর্টেন্ট একটি কোশ্চেন।
Yes, two things. One is the child has to be fed from mother's milk. So two things what can do, that is to avoid transmission for a temporary period of 10 to 14 days. The newborn child can be kept separated nearby, keeping the mother in isolation in the same house, and keeping the child in different room under continuous care of a very nice caregiver. Just milking the child by bringing the milk from mother and feeding the child. This is one way the child can be taken care of when the mother is suffering from COVID-19.
স্যার আরো যারা থ্যাঙ্কস দিয়েছেন আমরা জাস্ট তাদের একটু নামগুলো মেনশন করতে চাই। আলমুবিন, আজিজা প্রামাণিক, ডক্টর মোহাম্মদ শফিউল ইসলাম, উনি একজন অপথলমোলজিস্ট এবং উনি যেটা প্রকাশ করেছেন যে মনে হচ্ছে যে আমি আমার স্টুডেন্ট লাইফে আপনার ক্লাস দেখছি।
Very nice of him.
স্যার আব্দুল্লাহ আল কাইয়ুম তিনি জানতে চেয়েছেন হোয়াট ইজ দ্য রোল অফ ফেমোটিডিন ইন ম্যানেজমেন্ট, উনি জানতে চেয়েছেন।
Okay, there is an observational study in China. Recently, there is an observation which they observed that they have separated two groups of patients who did good, who did worse, and they followed the medicine they have been taking. They have found out by computer analysis that a groups of patients in China who were taking famotidine as their anti-ulcerant drugs, they were less severe, having less severe disease than those who were not taking famotidine. That gave a clue. Now, this has been discovered by a doctor, junior doctor of, I think, Harvard or Massachusetts General Hospital, I'm not sure. Now, they have taken up a study in which they will give intravenous high dose famotidine in patients who are symptomatic, and they probably will compare with other placebo and will do a randomized control trial. If the trial is on, we expect to see a result. So until and unless any study is supported by any medicine is supported by randomized control trial, we cannot for sure say that famotidine. But since the drug can be taken as usually, so no harm taking famotidine if you think that there is some benefit you may expect, because there is no specific treatment of this disease.
স্যার আরো কিছু কোশ্চেন আমরা নিতে চাচ্ছিলাম, আমরা দ্রুত শেষ করতে চাই। যারা থ্যাঙ্ক দিয়েছেন, আমি স্যার আপনার আলোয় আমিও আলোকিত হয়ে গেছি, কারণ স্যার অনেকে আমার নাম মেনশন করে থ্যাঙ্ক দিয়েছে। আমি তাদের নাম সাব্বির হোসেন, ফরহাদ তাসনিম, থ্যাংক ইউ স্যার। একজন আমাদের সিনিয়র স্যার কোশ্চেন করেছেন, এ কে এম রেজাউল করিম স্যার, হোয়াট ইজ দ্য ওপিনিয়ন অ্যাবাউট গণস্বাস্থ্য অ্যান্টিজেন অ্যান্টিবডি টেস্ট ইন দি সিচুয়েশন ইন আওয়ার কান্ট্রি? স্যার একটু সেন্সিটিভ ইস্যু, আপনার নিজস্ব কোনো মতামত থাকলে।
Actually, antibody test, আমি antigen test গণস্বাস্থ্য নিয়ে এসছে কিনা, I am not very aware of it, but so far I know that yes, they have proposed antigen antibody test. Any antigen antibody test to be given as a authenticity, I think that needs some validation and accuracy and validation, and clearly there are some stages they has to fulfill those stages that gives the test a reasonable footing. I'm not sure whether Ganashastro has produced those evidences which can unanimously say that their antigen antibody test can be regarded as valid and accurate. I'm not aware in this field.
ওনার স্যার আরেকটি কোশ্চেন আছে যে অ্যাসিম্পটোমেটিক এরিয়ার কতদিন পর্যন্ত সেটিকে স্প্রেড করতে পারে, উনি এটি কোশ্চেন একই।
Oh, this is one very important question. Actually, when all the patient starts the disease as asymptomatic carrier. So within 3 to 5 days, they start showing symptoms. And once they are recovered from the disease, they start to show recovery, and there is no viral shedding is seen. But it has been seen that there are few cases where it is reported that even after recovery, the virus was detected in their test. So what about these groups of people? You see, even after 3-4 weeks of recovery, if anybody's nasopharyngeal swab detects a positive virus, this does not necessarily mean that this virus is infective. To detect a virus which is infective, you have to have a sub-analysis or analysis. But they did it, and presence of a RT positivity after complete recovery, 3 to 4 weeks or 2 weeks after recovery, does not necessarily mean that the patient is again reinfected, or does not necessarily mean that this patient is transmitting disease to the others.
ডক্টর আব্দুল্লাহ আল করিম জান্নাতুল ফেরদৌস দিশা থ্যাংক ইউ জানিয়েছেন। আমরা সবাইকে থ্যাংক ইউ দিতে চাই। একজন খুব এক্সাইটেড হয়ে থ্যাংক ইউ দিয়েছেন ডক্টর সোনিয়া, তিনি থ্যাংক ইউ সো মাচ লিখতে গিয়ে স্যার অনেকগুলো শূন্য দিয়েছেন, সোর পর অনেকগুলো ও,
মানে trying to emphasize on the thanks.
and you are the best উনি বলেছেন। সিয়াম अगेन থ্যাঙ্কস। অনেকে আছেন আমরা সবার কাছে একটু Samira Rahat Afroz, thanks to Dr. Saklan and Sarver for bringing out Siddiqui sir. We missed him. Dr. Samira Rahat Afroz আপনাকে স্যার মিস করেছিল এবং এটা আমাদের সবারই কথা।
আমাদের হ্যাঁ ও স্টুডেন্ট ছিল।
ফেসবুকে স্যার এটি আসলে দেওয়া হচ্ছে, ফেসবুকে আরো অনেক ভিউয়ার্স আছে তারা যেটি বলার চেষ্টা করেছেন। ডক্টর ফেরদৌস খান আমরা সরি বলছি কারণ আমাদেরকে যেতে হবে। জীবনীরা another admin from DSDR group, তিনিও আপনাকে থ্যাংক ইউ দিয়েছেন। ডক্টর চঞ্চল, আমরা সবাই আপনাকে নিয়মিত চাই স্যার, এমন তথ্যবহুল ক্লাস করতে চাই। অসংখ্য ধন্যবাদ স্যার, অসংখ্য ধন্যবাদ সাকলাইন রাসেল ভাইয়াকে, মানে স্যার আমি আলোকিত যেটা বলছিলাম। পিজুর শাহ থ্যাংক ইউ, উনি আমিনা বিনতে আলী থ্যাংক ইউ, ফাহাম্মদ দীপু, ডক্টর আয়েশা আলম ক্রান্তি তিনিও আমাকে স্যার এবং আপনার মধ্যে আমাকেও।
আমি তোমার স্টোরিটা বলি কিভাবে আমি আসলে সন্ধ্যার পরে ইভিনিং ওয়াক করছিলাম, হঠাৎ দেখলাম আননোন কল আসছে। আননোন কল আমি সাধারণত ধরি না, তো আমি একটু পরে দেখলাম একটা মেসেজে দেখি স্যার আমি সাকলাইন আপনাকে কল করছি, আপনি যদি আমার সাথে কথা বলেন। পরে সাকলাইনকে আমি সাকলাইন দেখে তো আমি তাড়াতাড়ি আবার কল দেখতো না, তখন সাকলাইন আমাকে বলল স্যার হোয়াট ইজ দিস, আপনাকে নিয়ে আমরা কথা বলি, আপনাকে নিয়ে গল্প করি, কিন্তু নতুন জেনারেশন চেনেই না আপনাকে, নামই জানেন না। তো এটা আমাদের কাছে কষ্ট লাগে। ওর কথাটা আমাকে খুব হিট করছে যে অ্যাকচুয়ালি উই ফিল ব্যাড। আমি এক্স্যাক্টলি সাকলাইনের কথা বলতে আমার টোটাল বিএনসির সেই ব্যাচের সবার সেই আমি যাদেরকে পেয়েছিলাম সবার মুখ্য ছবিটা আমার কাছে ভেসে এসেছে। অ্যাকচুয়ালি মনে হয় দিস ইজ দ্য থিং। তারপরে সাকলাইনকে আমি বললাম দেখো সাকলাইন এখন তো চারিদিকে সবাই মানে এত চ্যানেল, আমাকে যে বিভিন্ন চ্যানেল বলে না আমি অ্যাকচুয়ালি অ্যাভয়েড করেছি। তখন সাকলাইন আমাকে বললো স্যার উই নিড টু গেট সামথিং ফ্রম ইউ। তখন আই রিয়েলি সিরিয়াসলি থিঙ্ক দ্যাট আই থট দ্যাট দেয়ার হ্যাজ টু বি এ কম্প্রিহেন্সিভ লেকচার which should cover all important aspect to create a foundation. আমার এই লেকচারটা একটা ফাউন্ডেশন হিসেবে কাজ করবে, অনলাইনে থাকবে, যারা এটা দেখবে তারা যদি এটা আবার দেখে they can always enrich their own knowledge and everything based on this foundation. আমি এই ফাউন্ডেশনটা করে দিলাম, making pathophysiology easy, try to make it easy. যে কেউ ঠান্ডা মাথায় যদি এখন প্যাথোফিজিওলজিটা নিজে বোঝার চেষ্টা করে, I think this is not very difficult. And viral replication, এই দুইটা জিনিস ভেরি ইম্পর্টেন্ট। আরেকটা জিনিস আমি যেটা এমফাসাইজ করতে চেয়েছি সেটা হচ্ছে রেসপিরেটরি ফেলিওরটা যদি ARDS হিসেবে ম্যানেজ হতে থাকে আইসিইউতে, তাহলে মর্টালিটি 88 to 90% পেশেন্ট মারা যায়। রেসপিরেটরি ফেলিওরটা ম্যানেজ করতে হবে নট অ্যাজ ARDS, এটাকে ম্যানেজ করতে হবে if আদৌ পেশেন্টকে ভেন্টিলেটরে দিতেই হয় with low tidal volume, okay, gentle breathing, so that patient can sustain 3, 4, 5 days, because immune system today or tomorrow going to take over and viral cytokine, these are all going to go over. Just allow some time to patient, support the patient to survive. That is why no aggressive therapy is needed in case of COVID-19, no matter how serious he looks, just supportive treatment.
ধন্যবাদ স্যার। আসলে তারপরও ওই স্মৃতিটা থেকেই গেল যে লেকচার ক্লাসে বসে যে লাইভ ক্লাস করার যে স্মৃতিটা আমরা মনে করি
এটা I would love that. আমি এইসব স্লাইড প্রেজেন্টেশন আমার ভালো লাগে। আমি যদি স্ট্রেট বোর্ডে দাঁড়ায় আমি যদি ওখানে দাঁড়ায় বলতে পারতাম এই সবগুলো, মানে given opportunity I could have said as you understand.
এটাই স্যার আমি বুঝতে পেরে বললাম যে জি এটা বুঝতে পেরে বললাম, কারণ হচ্ছে যে স্যারের যে লাইভ ক্লাসে যে আমরা লাইভলি থাকি এবং স্যার স্লাইড প্রেজেন্টেশনের ব্যাপারে খুবই বিরক্ত ফিল করেন যে আমি স্লাইড রিডিং, এটা আমার সবচেয়ে অপছন্দের কাজ, বাট আজকে করতে হয়েছে। স্যার আমরা শেষ করতে চাই, তার আগে একজন ডক্টর মৌসুমী কাদর, উনি গাইনির কনসালটেন্ট, উনি ফার্স্ট সেমিস্টার উনি তার লাইফে আপনার ক্লাস করেছেন এবং ইটস ওয়াজ অ্যামেজিং। তার কথা মতে ডক্টর মৌসুমী কাদের, উনি কনসালটেন্ট গাইনোকোলজিস্ট, উনি আপনাকে স্যার থ্যাঙ্কস জানিয়েছেন। আমরা একটু জানিয়ে রাখতে চাই ফ্রম মাই,
থ্যাঙ্কস দিয়ে দাও।
জি স্যার, থ্যাংক ইউ। এবং ফ্রম আমার দিক থেকে আমি একটু বলতে চাই যে আমি ডক্টর সাকলাইন আর অথবা আমাদের যে টিম আছে ডিএসডি এর একাডেমিয়া, আমার পক্ষ থেকে আমি আসলে একটু সবার কাছে ক্ষমা প্রকাশ করতে যাচ্ছি, কারণ আমি সবার কোশ্চেন গুলো নিতে পারিনি, সবাইকে হয়তো সমপরিমাণ এমফাসিস দিতে পারিনি। আমি সেই কারণে সময়ের কারণে আমি আমার এই অক্ষমতাটার জন্য ক্ষমা চেয়ে নিচ্ছি। একই সঙ্গে আমি আমার মডারেটর ক্ষেত্রে আমি প্রচলিত মডারেশন থেকে একটু বের হয়ে এসেছি বিষয়টাকে আরেকটু লাইভলি করার জন্য, সে কারণে আমি একটু সরি বলছি। অবশ্যই থ্যাঙ্কস স্যারকে, যে স্যার এত সুন্দর একটি ক্লাস নিয়েছেন এবং আমি মনে করি দিস ইজ দ্য বিগিনিং। এবং স্যার যে কয়দিন সুস্থ আছেন ইনশাল্লাহ আমরা তাকে এভাবেই ধরে নিয়ে আসবো, এবং এই ধরে নিয়ে আসার কাজটা টেকনিক্যালি সাপোর্ট দেওয়ার জন্য শতভাগ সফল সার্ভেয়ার, যারা সবসময় কাজগুলো করছেন, বিভিন্ন দেশের এবং দেশের বাইরের বিশেষজ্ঞদেরকে নিয়ে সে ক্লাস নিচ্ছেন। সার্ভেয়ারকে আমি আমার পার্সোনাল দিক থেকে থ্যাঙ্ক জানাতে চাই। স্যার আপনি অডিয়েন্স এবং সার্ভেয়ারের উদ্দেশ্যে যদি কিছু বলতে চান।
Finally, those who are with me in webinar and Facebook Live, I just expect that this lecture will do some benefit. I will try to make the management simple. I try to make the pathophysiology of the disease understandable. So, and virus, how the virus multiplies. So these are the three aspects of this lecture which will lay down a foundation. If anybody of you have been benefited in any way, then that is the success of this masterclass. And I think this is the first time in Bangladesh anybody dared to deliver a lecture as a masterclass. I don't know anybody beforehand tried any masterclass in Bangladesh. So I hope this will also open a gateway for people like us and senior colleagues like us who will be encouraged to deliver their lectures even better the way I have presented. I would rather thank everybody who are still with me from the beginning. I thank them all for their hearing, and especially I give thanks to my students. Everybody, if I would have seen their faces, I would have really enjoyed much, but unfortunately, there is no scope. And a special thank goes to Sakline. He, Andali, told me that Sir Sakline to celebrate I to celebrate it. I did not know that Sakline is enjoying the status of celebrity and everything. So these are good things. It makes me happy and proud of my students basically. And everybody, I want to thank, special thanks to Sakline and Andalip, and through Andalip, Serbia. I really enjoyed this, except few of difficulties which I faced, and I feel sorry for that. I'm sorry that it was not as perfect as I expected. But anyway, happy Ramadan, and I thank everybody from my side. I'll be happy to join you again and again. Thank you very much.
থ্যাংক ইউ স্যার, ভালো থাকবেন, আপনার জন্য আমরা শুভকামনা করি। আল্লাহ হাফেজ। থ্যাংক ইউ এভরিবডি, সবার জন্য শুভকামনা। একই সঙ্গে আমরা স্যারের সুস্থতার জন্য আপনাদের সবার কাছে স্যারের জন্য দোয়া প্রার্থনা করছি। আল্লাহ হাফেজ।